Thank you, Alison. Thank you for the kind words. I appreciate the invitation. The only reason I came this long trip is because of Alison. Alison is one of the key leaders with the Las Vegas Trauma Conference. She has been in the organizing committee for many, many years. And as you heard, this is the largest trauma conference in the world, the most prestigious trauma conference in the world. So this morning I'll talk about a topic which it shouldn't be very heavy for anybody. I know that we have students and residents and fellows, different disciplines. So I'll talk something which can go down well with everybody. And my topic is to talk about trauma, the history of trauma, where we started, where we are now, some big successes we had, but at the same time some big failures and what challenges lie ahead of us. The history of trauma has a paradox, a real paradox. 2,000 years ago, trauma really started transforming medicine into science, from magic to science, and it planted the seeds of modern medicine. Fast forward 2,000 years AD, 4,000 years later. Trauma is the least scientific of all major medical disciplines, maybe except for psychiatry. And there are a lot of reasons for that. Firstly, as you know, it's difficult to perform randomized studies in trauma. Secondly, often we practice dogma over scientific evidence. Thirdly, often we are slow to adopt new proven practices. And fourthly, we are quick to adopt new flashy practices without any scientific evidence. Now, in antiquity, internal diseases were considered as a disease of the god. You did something sinful, your family wrong something, did something wrong, and the gods are punishing you with the disease. And for these reasons, they would do sacrifices and they wear phylactic amulets just to keep this evil spirit away from you. This is in internal medicine. This is a famous papyrus. I'm sure a lot of you have heard of it. The Ember Papyrus, 1500 BC. And this papyrus includes 700 magical formulas. How to keep the disease away, the bad spirits away, and remain healthy. And they would use donkey, dog, gazelle, and fly dung to prevent or cure diseases. At the same time, there is another ancient Egyptian papyrus, the Edwin Smith Papyrus. Now, in this papyrus, there are 48 injuries, description of these injuries. And it's amazing. It's so scientific. They talk about objective clinical examination, diagnosis and prognosis of the disease, and the treatment options. Very scientific. They talk about hand washing and wound washing. They talk about sutures. For the first time, they suture wounds with linen. They use clean bandages. They put splints and immobilization for fractures. They prevent and cure infection with vinegar, honey, moldy bread. Perfect science. Vinegar. What's vinegar? Acetic acid. A few weeks ago, I had a patient with severe necrotizing soft tissue infection who developed Pseudomonas resistant to everything. How did we treat him? Acetic acid, vinegar. So there was real, good, strong science. In the Iliad, which was written 1200 BC, there is a description of 147 injuries. Swords, spears, arrows, slingshots, you name it. And there is a record of the first trauma surgeons. These two surgeons, Machaon and Podalirius, were brothers, and were the trauma surgeons of the Greek army. They were extremely highly valued and respected. During one of the battles, McCown was injured, and the king, the chief of the Greeks, says, "Stop it. Go and save McCown, because he's a man worth many men." So he was highly respected. The father of modern medicine is, as all of you know, is Hippocrates. And he had some very impressive scientific basis for the management of traumatic conditions. He talks about cleaning the wounds with clean hands, wash the wounds with water after boiling it. This is sterilization. And mixed with wine. Again, sterilization, antiseptic. Again, he describes sutures of wounds, dresses linen with bandages soaked in water, wine, oil, or vinegar. Again, antiseptic, good medical sense. And he pays attention to detail. Look at this right here. When you do the sutures, the knot should not be in the downward direction into the wound, but in an upward direction out of the wound. So he pays attention to detail. A little bit forward, you come to the Romans. Again, they went one step forward. They create the first military hospitals. And these military hospitals could be mobile, the way we have them now all over the world, or they were permanent structures in fixed fortifications. This is a ruin of an ancient trauma military hospital, and this is the reconstruction of this ruin in Germany. They had again an organized system. They had medics for evacuation of the injured, and these medics carry bandages and the first aid things. They had wound surgeons, and they had a director of the medical services. Now, all these nice things were forgotten for many centuries. They went back to black magic until the 19th century, where we really have a significant advancement of trauma care. And this came from Larrey, the chief of the Napoleonic army. He is considered as the father of modern military surgery. He introduced trauma care in the battlefield. He created field hospitals and a system of ambulances, and the famous one is the flying ambulance. The flying ambulance was something like that. It came in two versions. It could carry 2 injured people or 4 injured people, and they had the doctor, and they had nurse, and they had infantrymen. It was very impressive that they could reach any injured person on the battlefield within 15 minutes. Impressive results. It's the first person who introduced the field triage. Until that time, until Larrey's time, officers had priority. If an officer had a little cut on the face, he had priority over this soldier whose limbs were blown apart by a shell. He introduced now the system, the seeker go first. And he was highly respected, very loved by his army and enemy. And that's just as an example. During the Berezina War, they had to cross the river, which was flooded. And the soldiers passed him over their heads to the other side in safety. At the Battle of Waterloo, his enemy, the Duke of Wellington, saw him. And the English soldiers started shooting at him. And Wellington said, "Stop, this is Larrey, don't shoot at his direction." Later on, the Prussians took Larrey a prisoner. He was condemned to death. When they found who he was, they spared his life and they released him. So he was highly respected. His achievements were quite impressive. As I said, the response time was less than 15 minutes, and he introduced amputations in the field. And by doing this, he reduced mortality from extremity amputations from 75% to 10%. Now, most of the advances came from wars, and we heard about Larray. Fast forward to have the First World War, we have now the introduction of the shock treatment. We have now for the first time blood transfusions, we have crystalloids, we have portable x-rays, we have the introduction of Dager's solution, which we use today as well. And as an example, the mortality from femoral fractures dropped from 80% to 20%, a significant advancement. Second World War, again, some major advances in trauma care. We have now air evacuation, we have organized blood banks, we have the discovery of penicillin, the scientific care of burns, and we have now, for the first time, the concept of delayed primary wound closure. Korean War, now another advancement. We have the rapid helicopter transportation. We have again this superb field triage system, the MASH. We have tourniquets. Tourniquets is nothing new. They go back into antiquity, but they were really extensively used in the Korean War. They started blood transfusions in the field, and again they popularized vascular repairs. And again, to give you an idea, the amputation rate in the Second World War was 49.6% for vascular trauma. It came down to 20% in the Korean War, significant improvement. The Vietnam War, again, another major advancement. We have now the modern basis of pre-hospital care, the EMS system. We have now the paramedics or the doctors doing in the field surgical airways, the compression of tension pneumothorax, shock resuscitation. All of these were introduced in the Vietnam War. So we see a significant improvement from the time of injury to definitive care. First World War, 10 to 12 hours. Second War, 6 to 12. Korea, 4 to 6 hours. The Vietnam War, 1 hour. Now the recent wars, the global war on terrorism, again gave us some other major advances in trauma. We have now the widespread use of damage control surgery. That's a big thing. I think this concept saved more patients than any other surgical technique in trauma. We have now the concept of hypotensive resuscitation, new hemostatic agents, and again the widespread use of tourniquets. Again, we have very extensive use of decompressive craniectomies, much more common than in civilian trauma, and we have safe transportation in long distances of critically injured patients. We have now flying ICUs, flying patients, extremely critical patients, safely from Iraq to Germany, from Germany to the States with zero mortality. The massive transfusion protocol was another major product which came from the recent wars. So you can see that in the Vietnam War, from the time of injury to the time the injured patient touched American soil was 21 days. Now it's 72 hours. So it's a significant improvement. And again, you can see here that over the last few years in the recent wars, even though the injury severity score, the severity of the injury has been going up, the mortality has been going down. So that's a major advancement. So again, you can see the mortality going down over the last 3 wars, 30%, 24%, 10%. Now, these are advances in the military trauma. What have we done in civilian trauma? Did we do anything good, anything wrong? Well, the greatest advances are, number one, we accepted the lessons we learned from military conflicts. That's a good thing. The second good thing is the widespread introduction of trauma systems and trauma centers. Remember that the good trauma surgeon can save a few dozens, a few hundred lives in his career. The thing which will make a big difference is a trauma center, a trauma system. Well, again, historically, the first trauma center in the world was in England, in Birmingham. I visited this hospital. It's a beautiful facility. It was a beautiful facility. Now they moved to another one. The first trauma centers in the States were the shock center in Baltimore and the Cook County Hospital in Chicago. Now, in 1976, there was a report by the American College of Surgeons, and they summarized their recommendations in the optimal criteria for care of the injured patient. And the conclusion of that report was that trauma centers are the most effective way to improve outcomes. And they show that trauma centers will reduce early mortality by 30%, late mortality by 60%. This report and this recommendation led to a proliferation of trauma systems and trauma centers in the whole of the United States, except at rural areas. Unfortunately, and this is a huge problem today, this proliferation went completely out of control. And now it's done mainly for commercial reasons, financial reasons, or policy reasons of an individual hospital. And this unregulated proliferation has a major negative effect on patient care, on training, and the whole trauma system. And you can see this now in Florida. We started seeing this in other areas, including California. So that's something we need to take care of. And the American College of Surgeons is looking into that very seriously. This is a position statement by Dr. Stewart, the Committee on Trauma Chairman of the American College of Surgeons. In a recent interview with the Los Angeles Times, says it is important not to have too many trauma centers. Doctors and staff need a steady flow of patients to maintain their expertise. It's common sense. The more of something you do, you tend to do it better. So this is something we all need to have in mind and maybe not allow this uncontrolled proliferation to damage the whole system. Again, this is position statements from the American College of Surgeons. The AAST, the American Association for the Surgery of Trauma, is taking a similar stance that we need to stop this uncontrolled proliferation. There is a trauma center here, and then a private facility 1 mile down the road, they open another trauma center. It dilutes the experience for the students and the residents and the fellows and the surgeons. And as a patient, would you like to be treated in a trauma center which sees 10 complex pelvic fractures a year, or in a trauma center which sees 200 complex pelvic fractures a year? That's very simple. Now, in planning trauma systems and trauma centers, there was a lot of thought, and maybe the cornerstone of this thought was the famous trimodal distribution of deaths and the golden hour. In my opinion, are huge fallacies. There is not such a thing as a trimodal distribution of deaths. There is not such a thing as a golden hour. Now for the fellows and students, what is the trimodal distribution? According to this, which was published many years ago, decades ago, deaths due to trauma occur in three waves. That's a one, that's a second, and that's a third. 50%, 30%, 20%. This is hours and days after the accident. It does not happen, it does not exist. This is a study we did a few years ago. We analyzed more than 2,500 trauma deaths. And this is the distribution of death in penetrating trauma. What is the distribution of death? This is in blunt trauma. Completely different. I don't see distribution. These are the deaths because of head injuries. This is the distribution of deaths. This is the deaths due to chest trauma. There is not such a thing as trimodal distribution of deaths. Forget it. It does not exist, but everybody keeps saying this. You open a trauma textbook, and one of the things we are going to see in the introduction is the trimodal distribution of deaths. That's a myth. The other big myth is the golden hour. Everybody talks about the golden hour. You talk to a layman, you talk to anybody, yeah, golden hour, you do it right, everything is going to be fine. The golden hour is not an hour of 60 minutes. The golden hour varies from patient to patient. This patient with a cardiac injury, the golden hour is a few minutes. It's not 1 hour. This guy here with mesenteric tear, ischemia, non-bleeding, the golden hour can be a few hours. So we need to get this concept right in our brains. We have a lot of challenges. We made a lot of errors. And as you heard me saying earlier, these challenges include the difficulty in performing randomized studies in trauma. Again, dogma over versus scientific evidence. Thirdly, we do not want to accept new proven practices. And lastly, again, I repeat, we are very quick to adopt new flashy policies without any scientific evidence at all, and I will tell you about that. Okay, about randomized studies. It is possible to do randomized studies in trauma, but because they're trauma patient, it's difficult to get consent. You can do studies with exception from informed consent, but there are 55 pages of instructions and regulations. It really makes it extremely difficult, extremely expensive, extremely time-consuming to perform a randomized study in trauma. Now, let's come to the other big obstacle, dogma versus scientific evidence. Very often, you are going to hear people saying, this is what I was taught, this is what I teach, this is what I do, without scientific evidence. And I tell you an example. I can speak freely because it's a legal case which is closed. In June, I was asked to testify and defend a very well-known and nationally known thoracic surgeon on the East Coast. And I'll tell you about the case. The patient is a middle-aged lady, morbidly obese with a body mass index of 52, who has a thyroid disease, myasthenia gravis. She's hypothyroidic, hypertensive, and diabetic. And the surgeon planned to do a robotic surgery thymectomy. During introduction of the anesthesia, the anesthesiologist could not intubate. They tried rescue techniques, no way. The saturation went down, heart rate was in the 30s, and the team did a cricothyroidotomy. Now imagine doing a cricothyroidotomy on a patient with a body mass index of 52. It was difficult, but they saved her life. So they canceled the operation. They left the cricothyroidotomy there, and 7 days later, they went back. They got the anesthesia chief who managed to do and orotracheal intubation. They remove the cricothyroidotomy and they put a proper endotracheal tube. The surgeon did a beautiful robotic operation, and at the end of the operation, the patient looked fine. So they decided to extubate. They extubated, and the patient was not doing well. She needed retubation, and they reintubated, and at that time, they called the ENTs who did the formal tracheostomy. So initially, she had a cricothyroidotomy. Later, she had a formal tracheostomy. She did well, but she developed tracheal stenosis. So she goes to the ENT, and the ENT says, you know what? The surgeon who did the initial cricothyroidotomy should have converted the cricothyroidotomy into a tracheostomy within 48 hours, because this is the recommendation. The patient and the family hears this, and they sue the doctor that he did not convert the cricothyroidotomy into a tracheostomy within 48 hours. So they got an expert, a professor of ENT from California, who testified that the standard of care is to convert within 48 hours. And in his deposition and later in court, the lawyer asked him, where do you base this practice? He said this was recommended in 1922 by Chevalier and Jackson, and it's exactly what he used. I was in the court. He said, this is what I was taught, this is what I teach, this is what I do. Never mind that since 1922, there were a lot of studies which show that it doesn't really help. It might even make things worse. So this is the current thinking. I was taught, and this is what I'm going to do it, and I'm not interested about anything else. Another thing, it's in the textbooks. If it's in the textbook, it has to be right. And this is quite important for the younger faculty, the younger residents, and the students. That's not true. Or it has been the standard of care for decades. I'm going to keep doing this, it doesn't matter what the science shows. So I take you through the management of gunshot injuries because I have a special interest, and I'll share with you my own personal experience. In the 14th century, the standard of treatment for gunshot injuries is to pour boiling hot oil into the wound. And the reason for that, they thought that the gunpowder was poisonous, and in order to neutralize this poisonous gunpowder, they pour in this hot oil. So in the 15th century, Giovanni de Vigo, who was the surgeon of the Pope, wrote a book. And in this book, he described again this. The standard of treatment is to pour boiling hot oil, olive oil, into the wound. Now, because it's in a book, and because the surgeon of the Pope said this, it has to be absolutely right. So this is what they kept doing for the next 100 years. 100 years later, there was a war between France and Italy, and during the siege of Turin, the French surgeon Paré, he was a very young surgeon, was doing the same practice, pouring hot oil into the wounds. But he ran out of oil. So in a significant number of patients, he put just a regular dressing, no boiling oil into the wound. And this is what he said. He said, at night, I couldn't sleep. I felt terrible. I had nightmares that these patients treated without the standard of care, boiling hot oil, would suffer, would die. So early in the morning, he got up very quickly and he went to see his disaster. To his surprise, he saw that these patients, without the boiling oil, they're doing great. They are comfortable, no pain, no inflammation. On the contrary, those patients treated with boiling hot oil were in agony and pain and infections and fevers. And he said, from then on, I resolved never again so cruelly to burn poor men wounded with this shot. So this is how it started. Now, during the First World War, the surgical dogma was every patient with a gunshot injury to the abdomen should be managed operatively, operation. Maybe there was a good reason. During the Second World War, it became the standard of care. Every gunshot injury should be managed with an operation. However, there was a guy here, Dr. Shafter. He's one of the great fathers of trauma surgery in this country. He wrote an editorial in the Journal of Trauma in '69. And he said, you know what, maybe routine exploration for penetrating wounds of the abdomen is not justified in civilian practice. He went on to say routine exploration is a dogma, no longer valid for penetrating abdominal injuries. He was talking about both gunshot injuries and knife injuries. And he did a feasibility study for gunshot injuries, which shall prove that he was right. Now, in '74, I was a young surgeon in South Africa, and I read this article from him. He did a feasibility study. He analyzed more than 1,000 patients with abdominal gunshot injuries. And he found that more than 20% of these patients had no significant abdominal injury. That was a feasibility study. He suggested that perhaps there is a way to select these 21% of patients and manage them without an operation. And it's right. Many other series show that from gunshot injuries to the abdomen, only 70 to 80% have significant abdominal injuries. The conclusion was that maybe this 20 to 30% of abdominal gunshot injuries without an injury can be managed non-operatively. Okay, however, this did not happen. The dogma was maintained in the 70s and 80s. And these are some statements I got from scientific articles. Mandatory routine abdominal exploration for all gunshot injuries is advised. Another one. No attempt is made to identify a specific indication for laparotomy other than the presence of a gunshot wound. Another one. Laparotomy should be performed regardless of physical examination or estimated trajectory. This is dogma. Now, let's come back to my experience. I was a young surgeon in South Africa. And at that time, we started introducing this concept. So I did, with my friends, with my colleagues here, a prospective study. 146 patients with arterial abdominal gunshot wounds. And the decision to operate was made exclusively on physical examination. We found that 23.3% of these patients were successfully managed non-operatively, no deaths. In 7 patients, there was a delay by a few hours. The only complication was wound infection, nothing else. So I submitted this article to 3 American journals. All of them rejected it. Not only they rejected it, the reviewers were really nasty. They really hurt my feelings. They made me feel that I'm almost a criminal or an outcast. I was traumatized. And then one of my professors there said, why don't you send it to the British Journal of Surgery? The British Journal of Surgery is the highest impact journal after the Annals of Trauma. They accepted it. So they published it. I was very pleased. And I kept the reviews. I had them in my office in Los Angeles until a few years ago when we moved to the new hospital, and then I lost them because they were really, really hurtful. So in the States, things move very slowly. Many years later, in '94, there was a cautious move. Dr. Feliciano's group reported 13 cases with gunshot injuries to the right thoracoabdominal area managed non-operatively. That's a small advancement. But they say at this point, we cannot recommend non-operative management for any other than gunshot injuries to the right thoracoabdominal area. But it's a small step forward. Next year, there was a similar study. They reported 12 patients with gunshot injuries to the right upper abdomen. Now they have become a little bit bolder, and they say the role of expected therapy of abdominal gunshot wounds is cautiously advanced. This is in 95, so there is a little bit of progress. In 92, I was recruited by USC to start the trauma program in Los Angeles by Dr. DeMeester, and one of the guys there, the wise guys, was Dr. Byrne. At that time, this was the old hospital. We had a lot of gunshot injuries. 65% of trauma was penetrating, and most of these injuries were due to gunshot injuries. So my good friend Tom, I kept saying, Dimitri, we need to replicate your South African study of non-operative management. I did not want to do the study. I was very traumatized, and the last thing I really wanted is something to go wrong, and then I would have been executed in the middle of Los Angeles by everybody. They are looking over my shoulder. So I kept saying, yeah, Tom, I will do it. Don't worry. And I was hoping that he would forget. A few years later, a few weeks later, Dimitri, we need to do the study. Tom, yeah, we'll do it. I'm working on the protocol. I did not want to do it. At the very end, I was very embarrassed, so I said, okay, let's do the study. So we did the study. We didn't want to do the study until I saw another editorial by Nancy in the Journal of Trauma. It was an editorial, and the title was, "It is time we told the emperor about his clothes." And now he's an influential surgeon, and he says, the time has come to challenge the philosophy that accepts an unnecessary laparotomy in at least 20% of subjects. Selective non-operative management should be used for gunshot injuries, as it is already being used in patients with blunt trauma or stab wounds. So I did the study. I wrote the manuscript, and I did not want to submit it. Generally, when I write a manuscript, when I have the results, within 7 days I have the manuscript. After I have the manuscript, within 24 hours I submit it. For this one here, it was sitting on my desk for 8 months. And I became brave enough to submit it after I saw this article, these comments. So in this study, prospective study, we did with the Vermahos, you remember this guy, and Conwell, and Tom Byrne. Prospective study, 292 gunshot injuries to the anterior abdomen. Non-operative management, 30%. Bullet trajectory was not really always helpful. Even patients with likely peritoneal penetration, if they were clinically benign, were managed non-operatively. Next year, again, we did another study with gunshot injuries to the back, prospective 192 patients, 65% did not need an operation, perfectly safe, no disasters. Now, how about patients with obvious injuries, penetrating injuries to the liver, to solid organ? In 86, we are the first to suggest that in penetrating liver injuries, you can manage these patients non-operative. If the patient is fine and there is a little cut in the liver, why should I go in and do a big incision and maybe do nothing? So we found that in 1/3 of patients with penetrating liver injuries, we could do very well non-operatively. But this study in 86 was forgotten. Again, fast forward in 99, we did the same study in Los Angeles, gunshot injuries to the liver. Again, we found that in 21% of gunshot injuries proven on CT scan, we did not need to do an operation. And then we did another huge study, 152 patients with 185 penetrating solid organ injuries due to gunshot wounds, gunshot injuries to the liver or the kidney or the spleen. 27% were managed non-operatively, presented at the American Surgical Association, published in the Annals of Surgery. And the interesting thing is that even for severe liver injuries, grade 3 to 5, 24% did not need an operation. Yesterday, when I was at the LAX, I got a phone call from one of my ex-fellows. He called me, he said, Dr. D, you know, I had this yesterday. I had this patient with a gunshot injury to the right hypochondrium, and the CT scan showed that it went through and through the liver. But he's stable, and there is very little fluid around the liver. And they manage him non-operatively. And this morning, they are about to kick me out of the hospital. And this happened yesterday. Okay. Now, these are some examples of gunshot injuries to the liver managed non-operatively. You see, through and through. This is another. It looks big. But as you can see, very little bleeding around the liver, very little bleeding around the spleen or anywhere else. What do you want to do? If you are really desperately looking for trouble, please go ahead and operate on this stable patient. So this is another one, and another one, and another one, and another one. I can show you hundreds of CT scans. The same thing again for renal injuries, gunshot injuries to the kidneys. If it's an isolated injury and the patient is stable, 38% of these patients can be managed without an operation. The biggest satisfaction for an academic is to see his idea taken over by his residents and fellows who become later chiefs and embrace the idea and publish. And these are the guys now, they publish a lot, non-operative management of gunshot injuries, a lot. So I'm very satisfied, I'm very proud that this thing is taking over. It's taken over by my fellows and faculty. Now, we did a recent survey to see how this idea is spreading. So we surveyed 183 patients from 4 countries. Would you manage a gunshot injury to the abdomen non-operatively? In Canada, 30% said yes. Brazil, 45%. In the United States, 71%. But remember, it was 0% a few years ago. In South Africa, 100% would practice non-operative management. And again, interestingly, for those surgeons who completed the trauma fellow, 63% would do this practice. No trauma fellowship, only 39. Level 1 trauma centers, 67. Level 2 trauma centers, 59. So it depends very much on your experience in trauma. Is this applicable in the military? It seems so. Again, it's in a different environment, but maybe we need a better selection tool. This is a study from the UK. They analyzed 130 compact laparotomies during the recent wars. 21% of the laparotomies were not therapeutic. And look at this one here. 26% of negative laparotomies develop complications related to their surgery. So 21% did not need an operation. Those who did not need an operation, more than 25% had a complication. This is an American study by Dr. Mitchell and his colleagues, a 10-year review of all laparotomies, American combat casualties in Iraq and Afghanistan. 769 laparotomies for penetrating trauma. Non-therapeutic laparotomies, 31.6%. 1/3 of the patients injured in Iraq or Afghanistan undergoing laparotomy had a negative laparotomy. Obviously, we have a lot of work to do. My son is in the Marines, and I feel very strongly we have the Navy trauma training program. I believe that we have a long way to go. So, why shouldn't go non-operatively? Well, because a negative emergency laparotomy has a price. This is a review of nearly 1,500 non-therapeutic laparotomies for penetrating trauma. Early complications, abdominal complications, 10.5%. Feliciano reported 21%. I think it's too high. But overall, collectively, 1 in 10 of these patients will develop a complication. Late complications such as bowel obstruction or incisional hernia, again, is quite significant. On the other hand, do you worry? What happens if I miss an injury? You can go to diagnose it a few hours later. You miss an injury if it's small. You are not going to miss a big hole in the colon. You delay the diagnosis in a patient with a tiny perforation of the colon. And this is not the case which will give you a complication if you do the operation a few hours later. So these 720 observed patients, delayed diagnosis in 3.4%, no mortality, no increased morbidity. So it's quite safe. And I want to remind you the definition of a surgeon by Theodore Cocker, famous surgeon. A surgeon is a doctor who can operate and who knows when not to. And I want you to remember this. It's not a big thing to open an abdomen, find nothing and close it. But it's a big thing to say, this patient needs an operation, this patient does not need an operation. Now, the next challenge we face is that we are slow to adopt scientifically proven practices. Okay, and I will give you the example of the permissive hypotension in trauma. Now, everybody knows, and in the military is taught as well, that if you have penetrating torsal trauma and the blood pressure is around 90, 80, keep it there. Don't do aggressive resuscitation. This concept is not new. It was described by Cannon, famous physiologist, in 1918. It is very precise. If the pressure is raised before the surgeon is ready to check the bleeding, blood is solely, that is solely needed, may be lost. So you say uncontrolled bleeding, resuscitation equals more bleeding. He was ignored. Later on, during the Second World War, in 1943, again, the same concept, the same recommendation. A patient will not suffer if the skin is warm and of good color when the blood pressure is about 85 millimeters of mercury, because you are going to have more blood loss. Again, it was ignored. Later on, a lot of good experimental studies in the 60s, experimental uncontrolled extremity arterial bleeding. They report increased rate and volume of blood loss. In the 80s and 90s, experimental studies with abdominal aortic bleeding. If you resuscitate aggressively before control of the hemorrhage, the bleeding becomes worse. Completely ignored. More studies, again, these on splenic injuries, pulmonary vessels, all of them show the same thing. You resuscitate aggressively before you control bleeding, the mortality will be worse. It took a brave guy, Ken Maddox, to say, look, there is something wrong here. He did this study, and again, he confirmed what was told over decades. Now, this is an interesting, there was an interesting review. In this review, the authors estimated that in animal studies, if you do hypotensive resuscitation, the reduction of deaths is 41%. He extrapolated if the same thing was done in humans, 375,000 lives per year could be saved. I don't know if this figure is right, but I think it's an important thing to remember. Well, guess what? In 2002, the military recommended permissive hypotension if palpable radial pulse and normal mentation. This was recommended in 1918. It took 84 years before they adopted this, even though there was evidence. It was a classic example. Solid evidence not adopted. Okay, next one is exactly the opposite. We are quick to adopt new flashy but unproven practices. Oh, we like it, and somebody famous said it, and therefore it has to be right. And I'll give you a couple of examples. The factor 7 for traumatic hemorrhage and the must suit. Now, what is this factor 7? It was born in 1999 from a case report. It was in Israel. There was a soldier with a gunshot injuries. He was bleeding a lot. They couldn't stop the bleeding. And in despair, one of the surgeons gave factor 7. And for some reason, the bleeding stopped. The bleeding stopped because nobody knows. But he attributed this to factor 7. On the basis one case, poorly documented case, the whole practice changed, including myself, including the USC center. All the trauma centers were using factor 7 left and right. And you needed 2 doses. And the price for that was $17,000. The military at one stage, they ran out of factor 7. The military bought all the stocks because they were preparing for war. We couldn't find it. Unbelievable. Well, guess what? In 2005, this concept died from a randomized study. They did a randomized study. It says it does not really help. Classic example of quickly adopted as scientifically proven concept. Let's go to another thing, the must suit. The must suit was introduced during the Vietnam War as military anti-shock trousers. And again, no science, it looked good, so let's introduce it. In the 70s, it was introduced into civilian EMS. In 77, it was listed in the Committee on Trauma of the American College of Surgeons as an essential device. And in fact, many states made it an absolute requirement to have it in the EMS. Well, in 89, again, Mattox, he slays dragons left and right. He did a study. He says useless. So nobody uses must suit anymore. But that was another example. Practice introduced without any solid evidence. Well, I'll tell you the next spectacular failures. This is what I think is the pelvic binder and the reboa. Because there is very little research, we are very quick to adopt this, and they are potentially harmful. Okay, so let's talk binders, because I know that you use it, and we use it. Everybody uses it. It has become a standard equipment in most ambulances. It has been used liberally in the emergency room in suspected pelvic fractures. You feel a little bit the pelvis, maybe there is some pain. Okay, let's apply a pelvic binder. And it's recommended by the ATLS. Well, what is the use of the pelvic binders? Definitely, if the patient has a pubic symphysis diastasis like that, and you reduce the fracture, and you apply the pelvic binder, it's great. You reduce a fracture. But would you apply a pelvic binder to this patient here with a lock-in pelvic fracture? When you apply the pelvic binder, you really need to apply a lot of compression of the pelvis to reduce it, and then apply the binder. So would this more compression make the injury worse? For sure. The patient has a fracture of acetabulum, and you apply compression outside with the pelvic binder. Would you make it worse? For sure. The patient has an iliac wing fracture, and you apply this binder. Would you displace the fracture and make the pain and the bleeding worse? For sure. So we just did a study, 713 patients with pelvic fractures. Guess what? Only 3% of patients would have potentially benefited from application of pelvic binder, like this one here. 37% would have potentially been harmed, like this one here. And then 60% with posterior disruption, we do not know if it hurts or it helps. So at least in my place now, we will not apply a pelvic binder before we see an X-ray. There was a strong move to use the pelvic binders in all the Los Angeles County ambulances. I objected to that, and they do not have it, exactly for this reason. In fact, even for patients who were hypotensive, pelvic fractures are hypotensive, if we had applied routinely pelvic binders, they would have been potentially beneficial in about 6%, potentially harmful in 54%. Another idea. Now, something else which is close to my heart, which I think is done inappropriately, and this was introduced too quickly. We all know about damage control, and we all teach preperitoneal packing, and it's part of the ASSET course. For the younger residents, preperitoneal packing, if you have severe pelvic fracture and the patient bleeds a lot and you cannot stop the hemorrhage, you do damage control, and this is preperitoneal packing. In the preperitoneal packing, you open the abdomen, you stay below the umbilical, small incision, you stay outside the peritoneum, you find the bladder, and you go to the right of the bladder and you apply 3 packs, very tight, and then you go to the opposite side, another 3 packs, and then you suture the fascia to maintain tamponade. This is the preperitoneal packing. It does not make any sense to me for this reason. We completed an NTTB study, 321 patients with severe pelvic fractures, AIS higher than 3. Well, we found common or external iliac vessel lacerations in 11%. So do you think that if you have a laceration of the external iliac artery and you apply these 3 packs will be effective? No way. No way. In fact, we have a nice fresh cadaver lab, perfused cadaver, and we are busy now doing a study. We get somebody, a senior person, not a fellow, a senior person, doing good retroperitoneal packing according to the recommendations. We leave the packs there and then we go in and see where are these packs anatomically. Are they really near the vessels? Are they near the bleeders? Well, I tell you, they are 1 mile away from the major iliac vessels. So it does not work, it does not make any sense, anatomical sense. In addition to that, 34% had an intra-abdominal injury. So if you just do this without opening the abdomen, you might miss an intra-abdominal injury, which 17% bowel injury. Diaphragmatic injury 6%. Now in trauma centers, we usually do CT scans, and we might diagnose this, even though we can miss bowel injuries. But if you do this in an austere environment, in Afghanistan, without CT scan, without anything, you are most likely going to miss a major intra-abdominal injury. So this is another one which I think will go down the road. In fact, the EAST guidelines suggest that extraperitoneal pelvic packing in the management of pelvic hemorrhage remains unclear. But we teach it in the ASSET, in our books, everywhere. Now the next spectacular failure, and this I have the same idea as Dr. Mattox. Mattox thinks that is going to be the next spectacular failure, and I agree with him. The Reboa is the hottest trauma device in the last couple of years. Every respectable trauma center has it or plans to have it. We have it. We teach it on cadavers. We do it everything. And there are a lot of courses all over the world come to learn how to use the Reboa. It's still very experimental, very experimental. It's good to use it for experiments, to use it for studies. It's not ready for prime use. Now, there are 2 studies from Japan. The Japanese are very enthusiastic about Reboa, and they develop some elegant, smaller catheters. So they're really leaders. So they published two studies. One of them, they found that with Reboa, the mortality is significantly higher in the emergency room, significantly hospital higher mortality, 59% versus 38%. And then again, they did another huge study, 452 patients with Reboa matched with controls. And this is the conclusion. Reboa treatment is associated with higher mortality compared with similarly ill trauma patients who did not receive Reboa. So maybe there is a small group of patients which might benefit from that. We do not know yet. But you are so quick to adopt this technology. We need to stop and think. So what are the messages I want to give today? I think it's important for all of us, especially you, to challenge trauma practices not based on solid science. Number two, don't be the first to adopt new unproven concepts. But don't be the last to adopt concepts which have scientifically proven. And again, the most important message for the younger faculty and students and residents, be prepared to challenge what you are learning now. Listen to us respectfully, do what we tell you, but you don't have to believe it. Challenge it later on when you are in the appropriate position, challenge what we tell you. And with this, I conclude, and thank you very much for your attention. And very lastly, remember this, I'm prepared for progress. The only problem is that I do not like change. And I know that a lot of you, a lot of the younger people who want this change. Thank you. This is an important point. If you are unlucky to get severe trauma in a rural environment, your chances of dying are 3 times higher than in an urban center with trauma centers. And it's a big challenge, political, financial, and medical in every aspect. In my mind, you need to have, the best system I ever saw is the Swiss system, where they have a very quick, rapid transportation system with helicopters. You are in Switzerland or even in Germany, within maybe less than half an hour, you can be reached by helicopter, ambulance, and be taken to a trauma center. It's not practical to build a trauma center in a huge area with a small population. It's not practical. Whenever it's practical, and this is where I think we need feasibility studies and analysis. Whenever it's practical, I think they should try to establish trauma centers, at least level 2 trauma centers. But it is a big problem. It's then distribution of resources. Yeah, I think, yeah, another excellent question, which, again, we looked into that quite a few years ago. There are two reasons. Number one, especially the older generation trauma surgeons are not as good with laparoscopy as the younger generation. They can find gross things, big things, but not details. That's the number one. Uh, but the most important thing is that there is concern that for certain types of injury, laparoscopy is unreliable. And we did a study. I had an excellent laparoscopist, um, not a trauma surgeon. I did a study a few years ago, and I don't know how we managed to get IRB approval, but we did it. So we got patients with penetrating trauma to the abdomen, stable. So I got this guy, an experienced laparoscopist, to do the laparoscopy first and write down all the findings. And then we did the laparotomy, and we recorded our findings. Laparoscopy missed a lot of injuries, a lot of hollow viscous injuries, for sure retroperitoneal injuries. So this is one concern. The real documented value for laparoscopy is, number one, to rule out a diaphragmatic injury. So this is part of our protocol. If a patient has a penetrating trauma to the thoracoabdominal area, we'll wait for about 6 to 8 hours, and then we do a laparoscopy, and if there is a diaphragmatic injury, we repair it laparoscopically. The second area is VATS. The patient has a retained hemothorax, we'll use VATS for evacuation. And in some cases in ICU, where we worry maybe about viability of the bowel, is the bowel dead, ischemic, or whatever, we can do laparoscopy. But you are right, we haven't really gone very far. Some of the younger generation trauma surgeons are much more aggressive. I think it's a generational thing as well. One of my guys, excellent laparoscopy, did a laparoscopic right hemicolectomy for a gunshot injury to the colon. I wouldn't do it. I was expecting everything to fall apart, and I was going to hit him on the head with a chair, but nothing happened. The patient did well.
Do you think some of that also is, as we've changed, more and more they're going to the operating room because they're given an MFA unstable, or there's suspicion of a large injury, or we're expecting a manageable, as
Yeah.
opposed to perhaps a smaller, moderate injury that's medically stable that when the easily be treated with laparoscopy goes to something.
I agree, a significant number of patients are very unstable. You cannot really do laparoscopic evaluation on an unstable patient. But some of them are stable, and you decide to manage him non-operatively. Laparoscopy in this case, in my mind, and I'm biased, there are certain disadvantages with laparoscopy. Number one, you subject the patient to a general anesthesia, which is a big thing. Secondly, once you put the patient under general anesthesia, you lose the benefit of the clinical examination. You cannot examine him anymore. And thirdly, I think that the combination of the multi-detector CT scan and the clinical examination will give you an excellent diagnosis. This is my bias. Okay. Yep. You're right. You're right. The industry pushes a lot of these things. And I'll give you an example. At the AAST, there was a big thing. You know, the angel catheter, there is now this concept to put it for patients where you worry about DVT prophylaxis. You put a catheter through the femoral vein, and you inflate this filter. You leave it there for 5-10 days. And when the patient is at low risk, you pull it out. It's a temporary filter. And the industry is really pushing this very, very hard. And quite a few centers have introduced this. Now, when I ask him, okay, you put this femoral line, what is the risk of line sepsis if you keep it there, let's say, for 2 weeks in the groin? Secondly, you find, they said that before you remove it, you need to do a venogram to make sure that there is no clot in the filter. So I ask you guys there, so if you find the clot, what do you do? How do you remove it? Well, they say, in this case, we'll not remove the catheter. We'll treat him with anticoagulation and repeat the venogram. And when it's dissolved, the clot is dissolved, we pull the filter out. It doesn't make any sense to me. But as you pointed out, the industry is pushing so hard. And a lot of hospitals have adopted this concept. I have the reps calling me 2 times a week, even now in the aeroplane. They send me an email, that's very important, can I please come and meet you? So we need to resist these calls.
Well, I'd like to thank you for coming, and I appreciate your time.
Thank you very much.
We would like to present to you
I have a book as well.
a book as well, yes. So
Okay.
ours aren't quite as illustrated
West
by
Virginia.
us, but
Okay, thank you. Thank you very much. I appreciate
and
it.
a gift for
But
us.
thank
Thank you
you.
very
I
much.
appreciate
We appreciate it.
Thank you, guys.
Let's take about a 5-minute break. We'll let people go to the bathroom and whatnot, and then you're welcome to stay for the rest.
Appreciate it. Thank
And
you.
have you done any work in post-recovery rehabilitation